and I'd love to hear Saibul's opinion. But there's so much stuff happening in this space that it's going to be interesting to at least get a 30,000-foot view or a appraisal of stuff in the pipeline. So again, no real disclosure. So really, the big picture for TMVR, as in R standing for replacement with a capital R and a small r standing for repair, is that, I mean, I think replacement rather than repair typically is going to end up being used more liberally, just because the failure rates of repair in functional MR based on the CTSN data is 40% or greater at 2 years. And I just don't see that holding up. And hence, I think replacement is going to have a niche. Exactly how and where is still to be determined, because the MitraClip results completely changed the game for all the clinical trials that were in the field as far as where it fits in, because no longer is medical therapy the gold standard, but the MitraClip with optimal medical therapy is now clearly the gold standard. On the other hand, with DMR, I think the field is rapidly evolving, and quantification of MR is becoming more and more important, and the dependence on loading conditions and what the goals of treatment are. Just like some of the cases that were shown by Samir, where you have a 94-year-old with a severe MAC, obviously is not a candidate for surgery, in which case there's going to be some opportunity for a transcatheter DMR treatment in the repair side to take shape. So as we all know, surgical techniques are very complex. And this is an example of somebody who's getting his posterior leaflet that is excessive taken out, and a really delicate repair is being performed with a quadricuspid or tricuspid resection. Similarly, putting an undersized annuloplasty ring or annuloplasty as an anchor of some form of repair is kind of the gold standard of surgery when performed. But regardless, they have multiple tools available to handle different pathologies, which makes it a little tricky for us when we're doing a transcatheter approach, whether it's with an edge-to-edge repair or other forms of Neoport, et cetera, that we are unable to do more than one thing at the same time. The advantage we have is the ability to stage procedures. And I think that is something that definitely may come into play when we talk about the lifetime treatment of patients, especially with moderate risk that have 15 to 20 years of life expectancy still left. So this is really the summary of the surgical options. Like I was saying, they can do a lot of things, including annuloplasty, quadrangular resection, triangular resection, in addition, in terms of commissurotomy and papillary muscle fenestration, et cetera. On the other hand, with option of replacement, you can either go with a mechanical or a tissue valve. On the other hand, the newer devices coming out for a repair, in addition to just the edge-to-edge options with the MitraClip G4, which is the only FDA-approved device. You have Pascal and close second, hopefully will be out of clinical trials and available for use in the next year or two. And you have indirect anguloplasty using the annulus, using the coronary sinus with the Carillon, opportunities to do direct annuloplasty with the Cardioband, and it's more invasive and more involved, millipede and neocord implantation, which we'll talk about. My familiarity is with the pipeline device because it's in my backyard, and I've done and had the pleasure and opportunity of working on some preclinical and animal work as the device is being iterated to become mainstream. So like we said, transapical, transatrial platforms, I don't think are going to ultimately be in the forefront. I think transseptal technologies are what's going to be the, the, the pillar of how this technology will move. And I think, like I said, I have some familiarity with the pipeline. I did learn about the device called the Cardiomac, which is a mitral valve repair system, which is, again, transfemoral and transseptal with placement of a Neoport with tensioning that is in early feasibility studies and is actually with two PIs, Matt Williams and Mara Guerrero at the Mayo Clinic in NYU, with Steve Yakubov and Isaac George as on their advisory board. So this is stuff that's coming out, and is technology like this is going to be more and more you'll hear of in different forms. Like I said, degenerative MR is a leaflet problem, and currently we just are targeting edge-to-edge repair, but neochordal attachments with annuloplasty might end up being the cornerstone of more durable treatment. We all know that there are, Saibal mentioned this, a lot of non-ideal edge-to-edge cases. And typically, if you have commissural jets, wide jets, a really small mitral valve area, calcified grasping zone, and very degenerative Barlow's type valve, the results with mitral clip are often not to the extent that we'd like. Samir talked about this, really XTW and NTW. And you have 4 options depending on what your leaflet length is and depending on what the compromise is going to be tolerated in the mitral valve area, that you can tailor make your mitral clip options to be more precisely catered to the patient's individual anatomy. This is an example of what we're hearing about, a really broad jet, a really narrow mitral valve area. This was less than 4. And it was a case, again, nicely illustrating the ability to diagnose the tethering of the posterior leaflet all across the entire mitral valve. And the broad jet is obviously expected through both A2, P2, and extending both on the medial and lateral side of that. And ended up getting 3 clips, but all you have is 2 small orifices in the commissures. Luckily, the gradient was only 4. But these are the type of cases that are not easy and come across often, and that need to be that we need to find a better solution for. Pipeline, like I said, is another transfemoral transseptal chordal replacement platform. The advantage is it restores the geometry, maintains the neopapillary muscle tower, does not mess with chord angles and chord lengths, and obviously it preserves future options, which is kind of the important piece, like as I was mentioning. This is an example of a first-in-man case done, I think, in 2020 in South America with Jason Rogers, where they actually were able to implant the anchor in the LV and were able to put a pledgeted suture through and implant a neocord. Unfortunately, the challenge with this technology has been the ability to have a durable anchor within the LV. And in 2 or 3 days after the procedure, the patient unfortunately had a detachment of the anchor, recurrence of the MR, and hence Gore has gone back to redesign their anchor. And once that's done, I think this offers potential advantage in patients as a method to implant cords in patients with DMR. We talked about the direct anguloplasty with Cardiomac. It's a very involved procedure. It takes several hours, allows for restoration of the valve to a more functional state, and clearly enables reducing MR by reducing the annular dimension. This is a case that I got from Brian Wisenant a couple of years ago, in which it's a patient that he did where there was clearly improvement in the MR. The challenge is, of course, the fact that this is currently not being pursued at this time. Indirect Anguloplasty, Samir is a national PI for the study of the Carillon that leverages the proximity of the coronary sinus. It's 9 French. You implant it through the internal jugular. You have proximal and distal anchors. In cases where the MR is not as severe, the reduction in MR grade is not going to be as effective, but you can actually see how effectively you can put in anchors from the coronary sinus which allows approximation of the anteroseptal and mediolateral dimensions of the annulus, and hence reduce MR. What about TMDR with the S3 platform? So a lot of work has been done in this area, but it's really amazing for valve and valve, and amazing for certain cases for valve and ring, both of which have just recently have gotten FDA approval here. But a lot of work needs to be done for the valve and MAC cases. There's tremendous selection bias, complex issues with neo-LVOT and skirt neo-LVOT causing obstruction and potential need for adjunctive procedures like either lampoon and or alcohol septal ablation, oftentimes both. Bottom line is it currently allows us to treat about 50% of these patients who currently have no other options and where they don't qualify for participation in ongoing TMDR trials. Again, long-term durability, device migration, anticoagulation after surgery are all currently unresolved matters with this. This is a quick case of a valve that we did recently, which is a pretty nice and very, very good treatment option for these patients. Patient was a 68-year-old nurse with low ejection fraction in AFib, and you can tell that she had severe MR and severe MS as well, completely non-functioning bioprosthetic valve here, barely any motion. And you can see that here's a great example of using the techniques that Saibal and Samir showed you and getting a perfect transeptal targeted access using the Agilis sheet, using a 14 millimeter balloon to dilate the septum, Safari wire in the ventricle. You're able to get a sapien valve very nicely oriented and deployed within the failing bioprosthetic valve with excellent results and a minimal gradient at the end of the case. What about transcatheter replacement itself? Obviously, there are plenty of companies in this, but bottom line is two Edwards platforms, Evoke and M3, an Abbott platform with Tendyne, and an Intrepid platform with Medtronic are currently in clinical trials here in the US. We can talk about the trials a little bit. My familiarity is with the Tendyne Transapical platform, for which we were a clinical site, and I can talk a little bit more about that. But bottom line is that a lot of these are complex transapical, except for the M3, which is a transeptal, but involves a complex docking mechanism that's being, I think, iterated and is currently in clinical trials. But bottom line is that these are still early and will eventually come to fruition, I'm sure, but it's not ready for prime time, as they say. Again, the Intrepid has a transfemoral system in early feasibility studies, enrollment of about 30 patients thus far. It's 35 French transeptal, and you can see an example of how this is being deployed in a patient with valve and MAC. This is another interesting technology that I recently learned about at TVT last week, which is interesting to me, which is why I picked up a few that thought I would be shared with you all. One is this Dshaped mono-leaflet technique, where it restores physiologic LV flow. And again, in initial first in man with the transapical with some transeptal therapy in development. This is another interesting technology that involves wrapping the native mitral valve around the device. The animation here describes it beautifully. I thought this is a very clever design. It's currently in, I think, maybe just out of animal studies, but is being, an early feasibility study with this is being planned for a later part of this year. And I think Chitri Hall at the Mayo Clinic is potentially going to be a national PI for this. But the innovation and the animation here is incredible. You basically are able to come across and are able to, in a very creative way, weave a couple of a device across the leaflets and use that as an anchor to deploy your transcatheter valve. And so I'm sure there's more to come with technology of this type. My takeaway message for TMDR devices currently, they're all very super large profile. 2 of them are transapical, 1 of them is transfemoral. Patient selection is still going to be key. Currently, screen failure rates are still way too high. When used in the right patient, MR is completely eliminated, which is tremendous. Postoperative management of these patients, based on my experience with 10-9, is still very complex. It involves the heart failure team. They're often in the ICU on a balloon pump for several days until their afterload is optimized. And then ultimately, I think, like I said, for widespread applicability, a very simpler transseptal platform will be necessary. In conclusion, I want to say decision-making currently for mitral valve treatment options are complex, both for repair and replacement, and need individualization. The landscape is limited currently with edge-to-edge repair with the clip as the only FDA-approved device, and the S3 platform for valve and ring. The next few years, I think, don't bet against all these great new technologies that are still being fine-tuned. But regardless, I think you're going to need a center of excellence concept and involvement of the heart team to make good decisions for these patients. Thanks for your attention.